Good morning. Today I'm going to discuss with you critical concepts in management of hypertension. So this is a special workshop within the series of continuous medical education. So I reviewed more than 125 articles that are recently published, and I'm going to focus on these articles under these corners. I'll start with the introduction and special issues regarding how to monitor blood pressure. Then, if there are any guidelines in 2017, so I'm going to address Canadian guidelines for management of hypertension in adults that was released just 1 month. Nephrology perspectives of hypertension, so I'm going to tackle hypertension and chronic kidney disease, renal vascular hypertension, and other renal aspects. Management of hypertension and diabetes with pregnancy. I'm going to just focus on some antihypertensive drugs, especially diuretics, beta blockers, and the interactions between other drugs. And the last topic before conclusion will discuss hot issues and resistant hypertension, and then I close my presentation. Before I'm going to discuss the hypertension, we should be aware how to risk stratify the patients. So one of the important risk stratification is to know heart risk. And we are fortunate today because we have a lot of technology. So if we write on Google heart risk calculator, and then you will find this page. Just specify the age, the gender, race, write the total cholesterol in milligram per deciliter, high density lipoprotein cholesterol, and then again the blood pressure, systolic blood pressure, diastolic blood pressure, the patient is treated or not for hypertension, then diabetic or not, and smoker or not. Just click and you'll find, if we put these variables like this, you will find the risk for this patient is 42% 10-year risk of heart disease or stroke. And you will find within the calculator advices toward using of aspirin, high intensity statin for this patient, and the lines of treatment including thiazide, diuretics, ACE or ARBs, or calcium channel blockers. So all these are good facilities to stratify the patient to start with. One of important point is how to measure blood pressure, because it is a very amazing and very difficult to stabilize the environment within a research during the real clinical practice. So the advice is there are important elements for correct blood pressure measurement and technique. First, the patient should sit in a chair with his or her back supported and should rest for at least 5 minutes before the blood pressure is measured. Second, the patient's arm should be at the level of the heart. Third, the length of the blood pressure cuff's bladder should encircle at least 80% of the arm's circumference. Fourth, the clinician should inflate the cuffs to pressure 20 to 30 millimeter mercury above systolic pressure, as first identified by palpation of the distal pulse. The pulse disappears when cuff pressure exceeds systolic pressure. Fifth, the pressure in the cuffs should be released at a rate of 2 millimeter mercury per second. Sixth, the clinician should obtain at least 2 readings separated by at least 30 seconds, 1 or 2 minutes even, and average them. If these differ by more than 5 millimeter mercury, additional readings are necessary. The readings should be rounded off to the nearest 2 millimeter mercury. In some clinical scenarios, additional measurements are necessary, including those of the legs or opposite arm, or measurement taken with patient in different position. This article addresses the automated devices, and it seems that automated devices are very important, especially if we select the recommended automated device as I'll mention within the guidelines. Again and again, regarding the cuff, we should respect the cuff size, because this slide shows 3 sizes. So we have regular cuff bladder size, 12 by 23 centimeter, large cuffs between 15 and 15 by 33 centimeter, thigh cuffs 18 by 36 centimeter. If you use the regular cuff for arm circumference between 28 centimeter or less, it will be inaccurate for measurement. But if the arm circumference exceeds these values, between 29 and 42, 43 or more, you can find overestimation of the blood pressure by using this smaller cuff bladder size. If you use this bladder large size, 15 by 33 centimeter, it will be very appropriate and accurate for the arm circumference between 29 and 42 centimeter. However, it will underestimate blood pressure if arm circumference is smaller, and overestimates blood pressure measurement if arm circumference is bigger. If you use this big one, it will be inaccurate for arm circumference exceeding 43 centimeter, but it will underestimate blood pressure if the arm circumference is less than these values. So selecting the proper cuff size is one of the important points toward measuring the blood pressure accurately. So this is an important point. Regarding home blood pressure monitoring, there are practical information that should be addressed. So the technique: use only one arm, only an arm cuffs, not wrist or finger. Appropriately size the cuff to match arm size, as I mentioned in the previous slide. At least 5 minutes of quiet rest before measurements. Obtain readings in duplicate twice daily, morning before medication and evening before dinner for 7 days. Use the average of 7 days to make clinical decisions. In patients with high blood pressure variability, there may be value of measuring blood pressure more frequently than advised here. So this is the technique. Regarding interpretation, we should know that home blood pressure less than 125 by 76, the advisors continue to monitor. Or if the patient is treated with antihypertension, to continue the same treatment. If home blood pressure exceeds 135 by 85, start treatment or escalate therapy if the patient is already on treatment. If home blood pressure between 125, 76 and 135, 85, obtain ambulatory blood pressure monitoring. If 24-hour ambulatory blood pressure monitoring average is less than 130/80, continue same strategy. If higher, start or increase treatment. So we should put all these in our mind. Another important point is the presence of motion artifacts, because motion artifacts can lead to inaccuracy in blood pressure monitoring. So motion artifacts are considered external sources of inaccuracy, and it can be due to sudden arm motion, muscle tremor, shivering, and transport vehicle vibrations. In the proposed work of this article, a new algorithmic stage is integrated in a non-invasive blood pressure monitor. This stage suppresses the effect of motion artifacts and adjusts the pressure estimated before displaying it to users. The proposed stage is based on 3-axis accelerometer signal, which helps in the accurate detection of the motion artifact. Both transient motion artifacts and artifact due to vibrations are suppressed using algorithms based on empirical mode decomposition, EMD. So this means that we need to know how to monitor, how to measure blood pressure, and the different methods for accurate measurement. Let us to review the current guidelines of this year that is already accepted and is still we are waiting its publication for healthcare professionals who have been specifically trained to measure blood pressure accurately should assess blood pressure in all adult patients at all appropriate visits to determine cardiovascular risk and monitor antihypertensive treatment. Again, the grade is D. It is this is the grade of evidence. It is low grade, but it is recommended because this is the general advice for the general well-being of the patients. Use of standardized measurement technique and validated equipment for all methods. Automated office blood pressure, non-automated office blood pressure, home blood pressure monitoring, and ambulatory blood pressure monitoring. All these are recommended. And when we use any measurement technique, we should know the limitation and definition of hypertension based on the method of measurement. So if we use automated office blood pressure, the cutoff point for definition of hypertension is systolic equal or exceeds 135, diastolic equals or exceed 85. If we depends on the traditional method, non-automated office blood pressure, here 140 and 90 is the cutoff point for systolic and diastolic. Above them, or equal them, this is a stage of hypertension. If the systolic blood pressure, depending on non-automated office blood pressure, between 130 to 139 systolic, or 85 and 89 diastolic, it is high normal blood pressure. If we are depending on ambulatory blood pressure, according if we use awake values or the 24-hour values, if you are using awake values, if it is equal or exceeding 135 systolic, 85 diastolic, this is a hypertension. If we depend upon 24-hour ambulatory blood pressure, it is 130 and 80. If we use home blood pressure, if home blood pressure exceeding or equal 138, 135 and 85 systolic and diastolic respectively, this is hypertension. But if home blood pressure is less than 135, 85 and high office blood pressure, please repeat home blood pressure or ambulatory blood pressure. So this is the Canadian guidelines for adults. The use of home blood pressure monitor on a regular basis should be considered for patients with hypertension, particularly those with diabetes, chronic kidney disease, suspected non-adherence, demonstrated white coat effect, blood pressure controlled in the office but not at home, which is known as masked hypertension. Again and again, this is a very nice review, shows the association of nighttime home blood pressure with nighttime ambulatory blood pressure and target organ damage as a systematic review and meta-analysis. Within this meta-analysis, there is an accumulating evidence suggesting that nighttime home blood pressure monitoring is feasible and well accepted by the patients. Nighttime home blood pressure appears to have similar values as nighttime ambulatory blood pressure, and these monitoring methods are strongly correlated, have close agreement in detecting non-dippers, which is very important points, and give comparable association with indices of preclinical target organ damage. Due to its wide availability and low cost, this technique has the potential to be generalized in the primary care settings. However, there is need for further research to validate the optimal nighttime home blood pressure schedule, as well as outcome studies to confirm the value of nighttime home blood pressure versus ambulatory blood pressure in predicting cardiovascular events. So if we cannot do ambulatory blood pressure monitoring, looking at home blood pressure is very practical point, and myself I recommend this strategy. Another important question: is there a difference between isolated daytime or nighttime In the previous presentation, I stated that if I wanted to select between diurnal or nocturnal hypertension, I selected diurnal because nocturnal hypertension is more risky. In this study, the study addresses a question: is nighttime hypertension worse than daytime hypertension? A study on cardiac damage in general population. And this is the analysis that included 2,021 participants with valid ambulatory blood pressure monitoring. Subclinical organ damage was assessed by validated ECG and echocardiographic criteria. And the results, as shown in this figure, if we look at the percentage of individuals who had left ventricular hypertrophy, you can find there is no difference between isolated day and isolated nocturnal hypertension, but the risk is higher than the normotensive persons, and sustained hypertension persons had the highest risk of left ventricular hypertrophy. So again, both sustained nocturnal daytime hypertension are associated with risk of cardiovascular system. This is a very interesting point to look at the measurement of blood pressure, response of antihypertensive medication, and number of medications used by the patient. If blood pressure generally is less than 140/90, this is office blood pressure. This is controlled. If it is above 140/90, this is uncontrolled. So if it is controlled by 3 drugs, this is controlled hypertension. If it is controlled with the use of more than 3 drugs, this is controlled resistant hypertension. If the patient is uncontrolled with 2 drugs, this is uncontrolled hypertension. If the patient needs 3 or more, and principally one of them is diuretic, so this is the definition of resistant hypertension. And if the patient needs more than 5 drugs and the blood pressure is still above 140/90, this is a refractory hypertension. Again, this is just to enhance the exercise, because I know that the definitions, measurement of blood pressure are very crucial to start with. So let us to go to the different corners in this figure. If I start with this square, we have an individual who is not treated for hypertension. Office blood pressure is normal. Home or ambulatory blood pressure is normal. What's your diagnosis? The diagnosis is sustained normotensive individual. If we are dealing with the second corner, the person has high office blood pressure, normal home or ambulatory blood pressure. It seems that he has white coat effect, white coat hypertension. If we are in this third corner, high office, high home or ambulatory, this is sustained hypertension. If we are here in this corner, normal office, high home or ambulatory, this is masked hypertension. Masked hypertension means office is normal, but home or ambulatory is high. And this is another risky point for the left ventricular hypertrophy and other cardiovascular outcome problems. So this is regarding untreated persons. If the patient is already treated because of hypertension, and he is coming with normal office, normal home, and he is on drugs, so this is truly controlled blood pressure. If he is within this corner, high office, normal home or ambulatory, this is false resistant uncontrolled hypertension, white coat resistant uncontrolled hypertension. If the patient is here, normal office, high home or ambulatory blood pressure, this false blood pressure control, masked resistant uncontrolled hypertension. High office, high home or ambulatory, this means truly resistant uncontrolled hypertension. Again, we are using 135/85 for home and daytime ambulatory blood pressure monitoring, 130/80 for 24-hour ambulatory blood pressure monitoring to say normal, or 120/90 for nighttime ambulatory blood pressure to say this is normal or controlled blood pressure. Another important point regarding blood pressure trajectory, which is another point to be respected. This study included 762 participants of Ranco Bernardo study, and this is the different trajectories. Trajectories mean the direction of systolic blood pressure. So systolic blood pressure trajectories were derived using group-based trajectory modeling. This is the method. And Cox proportional hazards analysis was used to investigate association of trajectories and average systolic blood pressure with cardiovascular disease and all-cause mortality, adjusted for age, sex, cholesterol, smoking, diabetes, and antihypertensive medications. Mean baseline age was 65 years, and 67% were women. 4 trajectories were identified in which mean systolic pressure increased by 5 to 12 millimeter mercury during 10 years. The highest trajectories were associated with 2 to 3 times greater cardiovascular mortality and 1.5 times greater all-cause mortality risk compared with the lowest trajectory. Each 20 millimeter mercury increment in average systolic pressure was associated with 1.4 times greater cardiovascular mortality and 1.2 times all-cause mortality. So this is what is known about the topic, and what is this study is added. And in addition to what I said, systolic blood pressure trajectories were not superior to the average systolic blood pressure in predicting cardiovascular disease and all-cause mortality. This means we need to refine our tools to know blood pressure even more. You can have normal brachial pressure as measured in the office, but high central systolic pressure as known from the pulsed wave analysis. This study discussed an important issue, which is using the central systolic pressure. This study included 100 patients with well-controlled hypertension. They were analyzed for central systolic blood pressure estimation, and this was smart because they used the arteriograph tension med limited, which uses one cuff for all measurements, single point measurement approach, and the high proportion of treated hypertensive patients had central systolic blood pressure level that exceeded their brachial blood pressure. So central systolic blood pressure, so long as central systolic blood pressure positively correlated with lower height and shorter return time of the reflected pressure wave, and was significantly higher in female compared to male. So we should put all these variables in our mind. Again and again, we need to refine blood pressure measurement. I attended the 18th conference of Dumyat for cardiovascular and diabetes conference, and this was one of the presentations there, blood pressure variability, a masked enemy. So even if it is debated, I don't like variability in anything in medicine, because variability can be considered as unphysiological. And within this presentation, Professor Ragab mentioned short-term blood pressure variability within 24 hours, very short beat to beat, short within a 24-hour period, minute to minute, hour to hour, and day to night, and long-term blood pressure variability, day to day, visit to visit, seasonal. However, we should think of artifact variability. What are the causes of artifact variability? Patient position, patient relaxation, arm support, arm position, equipment used, calibrated or not, cuff size, appropriateness, release of the cuff, fast or not, multiple measurements, discussing and reporting. So all these should be put in mind before we discuss the variability. And this is one of the nice articles addressing a question: does blood pressure variability predict the outcome of acute ischemic stroke? And in conclusion of this article, blood pressure variability after the first 24 hours of acute ischemic stroke appears to represent a promising tool for the prediction of long-term outcome. However, larger studies are needed to confirm these findings. If this association is validated, interventional studies using antihypertensive agents with different effects on blood pressure variability are needed to clarify whether decreasing blood pressure variability will translate into better outcome. A very interesting point is this study, because the study included approximately 2,000 individuals aged 25 to 41 years, addressing the correlationship between healthy lifestyle and blood pressure variability in young adults. So the lifestyle score for 0 to 7 was calculated by giving 1 point for each of the following components: never smoking cigarettes, adhering to healthy diet components, never performing moderate or intense physical activity, having a body mass index less than 25 kilogram per square meter, a total cholesterol less than 200 milligram per deciliter, glycated hemoglobin less than 5.7%, or a conventional blood pressure is less than 120/80. Standardized ambulatory 24-hour measurements were obtained in all individuals. Blood pressure variability was defined as a standard deviation of all individual ambulatory blood pressure recordings. So this is a very interesting study, and they concluded that young and healthy adults adopting a healthy lifestyle was associated with what? With lower blood pressure variability. And these associations were independent of the mean blood pressure levels. So very interesting. If we go to the last year guidelines for the diagnosis and the management of hypertension in adults regarding the sector of suspected blood pressure variability, the recommendations are: for high-risk patients with suspected high variability in systolic blood pressure between visits, a focus on lifestyle advice and consistent adherence to the medication is recommended. So should think of these two important parameters. Drug therapy should not be selected based on reducing blood pressure variability per se, but in accordance with current recommendations, which already prioritize the most effective medications. Both of these recommendations are strong recommendations. And the most important point is we should refine our measurement of blood pressure to be unified all through the follow-up visits, and at the end selecting the best treatment for the patient. This will keep the blood pressure within a stable fashion and to avoid variability. As I mentioned, although you may find some debated issues regarding variability in different parameters in medicine, but I don't like variability in any physiological point. Here we are speaking about variability in blood pressure. Let us go to the second sector of the presentation, and in this workshop, treatment strategy, goals, and approach. And principally, I'll use the Canadian guidelines for adults. Here, we are stressing on the healthy lifestyles. We should encourage physical exercise for non-hypertensive individuals to reduce the possibility of becoming hypertensive, or for hypertensive patients to reduce their blood pressure. Prescribe the accumulation of 30 to 60 minutes of moderate intensity dynamic exercise like walking, juggling, cycling, or swimming 4 to 7 days per week, in addition to the routine activities of daily living. This is grade D. Higher intensities of exercise are not more effective. This is an important point. So just advise your patients for walking. For non-hypertensive or stage 1 hypertensive individual, the use of resistance or weight training exercise such as free weight lifting, fixed weight lifting, or hand grip exercise doesn't adversely influence blood pressure. Weight reduction, another important point to be tackled, to measure waist circumference for our patients, because visceral obesity is bad for cardiovascular, especially if it's coincident with hypertension. So maintenance of healthy body weight, body mass index less than 25 kilogram per square meter, and waist circumference less than 102 centimeter for men, or 88 for women. This according to the Western guidelines, and you can find differences according to the races. And for hypertensive patients to reduce blood pressure, all overweight hypertensive individuals should be advised to lose weight. And this is a grade B evidence. Weight loss strategies should employ a multidisciplinary approach that includes dietary education, increased physical activity, and behavioral intervention. So exercise, weight reduction, and a DASH. What's meant by DASH? Diet approaches stop hypertension, less in calories, high in fibers, fruits and vegetables. Reducing sodium intake towards 2000 milligrams. This means 2 grams sodium. That equals 5 grams of sodium chloride per day. And this is grade A evidence to cut short salt. In patients not at risk of hyperkalemia, increasing dietary potassium to reduce blood pressure. Both of these recommendations carries grade A evidence. And this is from current up to date, showing the modification in lifestyle and its repercussion on blood pressure. So weight reduction may lead to 5 to 20 millimeter mercury drop per 10 kilogram weight loss. Adopting DASH diet, 8 to 14 millimeter mercury loss, drop in blood pressure. Dietary sodium restriction to 8 millimeter mercury decrease. Physical activity 4 to 9 millimeter mercury decrease. Reduction in systolic blood pressure. Moderate alcohol consumption here. This is the results of these. This is a very philosophical article. Still, it's just accepted. Discussing the role of salt. Is salt a culprit or an innocent bystander in hypertension? A hypothesis challenging the ancient paradigm. And this review is very interesting, suggesting that consumption of high salt diet is not the cause of hypertension, and that there are other factors such as added sugar which are causative for inducing hypertension and cardiovascular disease, as you see in this figure. Promoting wide sodium restriction, reduction in sodium content of food but stable physiological drive to consume sodium, increases consumption of low sodium foods to meet unchanged physiological sodium demand, great intake of refined carbohydrates, trans fats, and other unhealthy components with greater intake of processed foods. At the end, increased incidence of hypertension, obesity, insulin resistance, type 2 diabetes, and cardiovascular disease. So again and again and again, we should look at the diet a multidisciplinary approach. Yes, salt restriction should be. We shouldn't advise high salt intake for hypertensive individual, even if the role of salt in causation of hypertension is minimal, as stated in this review. But we should stress on salt restriction to the level that I mentioned, 2 gram sodium, that equals 5 gram sodium chloride. And we should concentrate on the other component of the diet. We avoid processed foods, high calories, etc. It's a very interesting review that shows the important parameter, sodium excess and potassium deficit enhances central sympathetic nerve activity. This is a very interesting point because sodium excess and potassium deficiency act centrally on the brain, leading to increasing the central sympathetic nerve activity, raising peripheral vascular resistance, and generating hypertension. The central effect of sodium and potassium involves several signals arising from blood stream and CSF as non-circulating brain renin angiotensin aldosterone system, and the local production of endogenous whooping. Potassium administration, this is a very important point, is a powerful natural antidote for sodium excess. This is why in the guidelines they stated sodium restriction and giving potassium, and this is another, I want to repeat, this is a grade A evidence. If you are not afraid of hyperkalemia, reduce sodium and allows potassium to control blood pressure. Again, we are coming back to the Canadian guidelines. regarding the medical treatments of hypertension, when to treat. When to treat hypertension, antihypertensive therapy should be prescribed for average diastolic pressure of 100 or average systolic pressure of 160 or above. This is grade A evidence. In patients without macrovascular target organ damage or other cardiovascular risk factors. So we should evaluate the cardiovascular risk. If there is no cardiovascular risk factors rather than blood pressure and no evidence of macrovascular damage or target organ damage, we can start treatment if systolic blood pressure exceeds 160 or diastolic 100. Antihypertensive therapy should be strongly considered for average diastolic above or equal 90, systolic above or equal 140, grade B, in the presence of macrovascular target organ damage or other independent cardiovascular risk factors. So we treat the patient overall. So we should evaluate the risk first before deciding the treatment. This is a very interesting point. If there is cardiovascular risk factors, we treat earlier to the level 140 and 90, as I mentioned. Recommended monotherapy after adopting healthy lifestyles for all, exercise and diet, we can start with monotherapy. Thiazide-like diuretics, this is a grade A evidence. Was longer acting diuretic preferred, like chlorothalidone or indapamide, as I'll mention in the diuretic sectors. Grade B. Alpha blockers in patients younger than 60 years. Beta blockers in patients younger than 60 years. Grade B. Angiotensin converting enzyme inhibitor in non-black patients. Grade B. Angiotensin receptor blocker. Grade B. Long-acting calcium channel blocker. Grade B. So these are the drugs of first line for management of hypertension, starting at monotherapy, as I mentioned. Recommending single pill combination choices are those in which an ACE inhibitor is combined with calcium channel blocker. This is a new guideline, level A. ARBs with calcium channel blocker, grade B. ACE inhibitor with diuretics or ARBs with diuretic, grade B. Hypokalemia should be avoided. As I mentioned, potassium is important for regulation of blood pressure, and it is a friend for treating hypertension. So hypokalemia should be avoided in patients treated with thiazide-like diuretic monotherapy, grade C. A very interesting paragraph in the guidelines. Alpha blockers are not recommended as first-line agent for uncomplicated hypertension, grade A. Beta blocker are not recommended as first-line therapy for uncomplicated hypertension in patients 60 years or older, grade A. ACE inhibitors are not recommended as first-line therapy for uncomplicated hypertension in black patients, grade A. However, these agents may be used in patients with certain comorbid condition or in combination therapy. All these are very important points to put in our mind when we decided to use the antihypertensive treatment. This is a women's health across the nation prospective cohort study, included 3,000 women, discussing the effect of race and ethnicity on antihypertensive medication utilization among women in the United States. So this is the main results. Among this larger cohort of multicentric midwife women, use of antihypertensive medications increased over time, with angiotensin converting enzyme inhibitors or ARBs becoming the most commonly used antihypertensive medication, even for blacks. Thiazide diuretic utilization is increasing over time for all race, as did use for calcium channel blocker among blacks. So here the use of calcium channel and diuretics in blacks is increasing. Both patterns are in line with guideline recommendations. So this is just to show this. A very interesting point, chronotherapy, following the blood pressure all through the 24 hours, day and night. So put in mind, a pill in the night makes everything right. So a pill at bedtime and your heart is fine, bedtime hypertension chronotherapy, and opportune and advantageous inexpensive treatment strategies. So just distribution of the blood pressure management through the day, which is known as chronotherapy. And here I want just to advise, if we use more than one drug, so it's better to put one in night, so at bedtime. But be careful. I think diuretics are not preferred to be taken before night, before bedtime. So use any drug except diuretics at bedtime. This may add a lot for the management of hypertension. If we go together to the compelling indications, if you have heart failure, the best drugs, diuretics, beta blocker, ACE inhibitors, ARBs, aldosterone antagonist. Post-myocardial infarction, beta blockers, ACE inhibitors, aldosterone antagonist. High coronary disease risk, diuretics, beta blocker, ACE inhibitors, calcium channel blockers. Diabetes, diuretics, blood pressure, ACE inhibitor, ARBs, calcium channel blockers. CKD, ACE inhibitor or ARBs. Recurrent CVA, diuretics, calcium channel blockers. So according to the patient situation, we may select the proper drug. According to the up-to-date, systolic heart failure, ACE inhibitor, beta blocker, diuretic, aldosterone antagonist, and even using sacubitril neprilysin inhibitors, which is currently stated in the guidelines. Post-myocardial infarction, ACE inhibitor, beta blocker, aldosterone antagonist. Proteinuric chronic kidney disease, ACE inhibitor or ARBs. Angina pectoris, beta blocker, calcium channel blocker. Atrial fibrillation, beta blocker, non-dihydropyridine calcium channel blockers. Atrial flutters, beta blocker, non-dihydropyridine calcium channel blockers. Likely to have favorable effect on symptoms in comorbid condition. Benign prostatic hyperplasia, alpha blocker may help. Essential tremors, beta blocker may help. Hyperthyroidism, beta blocker may help. Migraine, beta blocker may help. Osteoporosis, diuretics because of anti-hypercalciuric effect, hypocalciuric effect of thiazides, helps in management of osteoporosis. To overcome Raynaud's phenomena using vasodilator like dihydropyridine calcium channel blocker may help. These drugs are contraindicated in these situations. ACE inhibitors in the presence of angioedema, beta blockers in bronchospastic disease, reverberating depression, methyl-dopa in liver disease, ACE or ARBs or renal inhibitors in case of pregnancy, beta blocker, non-dihydropyridine calcium channel blockers in the presence of second or third degree heart block. Beta blocker has side effects in the presence of depression. Diuretics may increase the risk of gout. Aldosterone antagonist, ACE inhibitor, ARBs, renal inhibitor increase the risk of hyperkalemia. Thiazide diuretics, hyponatremia. ACE inhibitor, ARB, or renal inhibitor in the case of renal vascular disease to be caution or increasing adverse effects. So we should look at the patient as a whole and selecting the best for the best in the same moment, because this is a personalized medicine. Selecting the best treatment for certain individual in a certain time point according to risk factors. Regarding the combination, there is a philosophy of combination, and this is the color-coded. The green line means recommended and preferred combination. So calcium antagonist plus angiotensin receptor blocker, calcium antagonist plus ACE inhibitor, calcium antagonist plus diuretics. All these are green line. Diuretic plus ACE inhibitors is green line. So all these are preferred. The red line is a warning sign. So please don't combine ACE inhibitors and angiotensin receptor blocker together because of the risk of renal failure and other side effects. So, and if you follow the other lines, this is dotted green, useful, dotted black, possible but less well tested, and the red not recommended. As I mentioned, the green is preferred. Again, I'll start to look at certain individuals who have high systolic blood pressure equals or exceeding 180 and diastolic 110 millimeter mercury without symptoms. How to manage? So this is severe asymptomatic hypertension. This table shows the medical how to tackle medical history in evaluation of severe asymptomatic hypertension. So look at previous hypertension, duration and levels, personal history, discussing all these points, coronary heart disease, congestive heart failure, etc. Risk factors: family history of hypertension, hyperlipidemia, diabetes, tobacco, smoking, others. Secondary causes: family history of kidney disease, personal history of renal disease, medications and illicit use of different drugs, metabolic disorders like thyroid disorder, pheochromocytoma, hyperaldosteronism, target organ injury damage, neurological headache, vision change, seizures, neurological deficits can be close for neurological. This is a very important clinical point. Chest pain, shortness of breath, myocardial infarction, syncope, history of palpitation or arrhythmias for cardiovascular, oliguria, even anuria for renal, acute shutdown, claudications, cold extremities, weak distal pulses for peripheral arterial diseases, sleep apnea, chronic lung disease for pulmonary disorders, concurrent medications, and I'll give a slide for the concurrent medication later on, compliance and antihypertensive. So we should ask about all these points. We should follow the proper blood pressure recording as I discussed. An appropriate size cuff, initially measured, should be obtained in both arms, and the higher blood pressure should be used. Significant differences between arms occurred in aortic coarctation, subclavian artery stenosis. The patient should have an empty bladder and remain seated with leg uncrossed for 5 minutes before the measurement. The measurement should occur at the level of the heart with the arm resting on a table. Postural blood pressure should be obtained in older adult. A minimum of 2 readings should be obtained 1 to 2 minutes apart and averaged. The diagnosis of hypertension should be confirmed at a subsequent visit unless the blood pressure reading is very high or the patient is symptomatic. Evaluation of white coat effect, as I mentioned before. The recommendations, and this is a clinical recommendation: patients with severe elevated hypertension should have a history and a physical examination to distinguish between severe asymptomatic and hypertensive emergencies with evidence of end organ damage. This is the evidence C. A 30-minute rest period is recommended when the initial blood pressure reading is severely elevated. In more than 30% of patients, the blood pressure will lower to an acceptable level without intervention following the rest period. An immediate diagnostic evaluation is not required in the initial management of severe asymptomatic hypertension, although the majority of them may be confronted in the emergency department. Aggressive lowering blood pressure, this is the most important point that I want to address. We should avoid drastic reduction of blood pressure, rapid reduction of blood pressure, because of the bad consequences. Aggressive lowering of blood pressure can be harmful and should be avoided in patients with severe asymptomatic hypertension. Gradual reduction over several days to weeks is recommended. Blood pressure control is best achieved with initiation or adjustment of antihypertensive. Current recommendations are to gradually reduce blood pressure over several days to weeks. However, if you opted to use correction over hours to days, the suggestion is to lower blood pressure to just 160 over 80, from 180 to 110 to 160 or to over 100, or to level that is not more than 25 to 30% lower than the baseline blood pressure. Here I want to stress upon one of the old bad habits by using sublingual nifedipine. Sublingual nifedipine is contraindicated in this setting and should not be used. This is a very interesting point. Regarding the goal of blood pressure, the goal of blood pressure was discussed through decades, and this was the GNC 8 that was published in 2014. Here, generally for patients 60 or above, the goal is 150 over 90, and these are the lines to be used. If it is less than 60 years, this is the target, 140 over 90, diabetes 140 over 90, CKD just lower than 140 over 90, and this is the used treatment. According to this year's recommendation that was published by American College of Physicians, the Annals of Internal Medicine, ACB and the family medicine physician recommend the clinician initiate treatment in adults aged 60 or older with systolic blood pressure persistently at or above 150 to achieve target pressure systolic just lower than 150 to reduce the risk for mortality, stroke, and cardiac events. This is a strong recommendation based on high quality evidence. So they recommended that clinicians select the treatment goals for adult ages 60 or older based on periodic discussion of the benefits and harms of a specific blood pressure target with the patient. Recommendation 2, they recommended the clinician consider initiating or intensifying pharmacological treatment in adults aged 60 or older with a history of stroke or transient ischemic attack to achieve systolic pressure less than 140 to reduce the risk of recurrent stroke. And this is weak recommendation, moderate quality evidence. And they recommended that clinicians select the treatment goals for adult above 60 on periodic discussion of the benefits and harm. The third recommendation is that clinician consider initiating or intensifying pharmacological treatment in some adults aged 60 or older at higher cardiovascular risk based on individual assessment to achieve target systolic blood pressure less than 140 and to reduce the risk of stroke. And this is the post hoc analysis of validation studies showing that in elderly persons systolic blood pressure kept between 130 to 145 shows the best with lower cardiovascular events, and followed by the less than 130, and it is bad if it is left above 145. So the guidelines of the Canadian guidelines for the isolated systolic hypertension, initial therapy should be single agent therapy with a thiazide-like diuretics grade A, long-acting dihydropiridine grade A, or an ARB grade B. If there are adverse effects, another drug from this group should be substituted. Hypokalemia should be avoided in patients treated with diuretics monotherapy. Additional antihypertensive drugs should be used if target blood pressure levels are not achieved with standard dose monotherapy. Let me just to go to the one of the most interesting trials published in the management of hypertension. It was published 2 years ago in the New England Journal of Medicine and is known as SPRINT trial because it opens the horizon for intensive blood pressure control. This study included 9,361 non-diabetic persons with systolic blood pressure of 130 or higher and increased the cardiovascular risk, and were randomly assigned to systolic blood pressure less than 120 or just less than 140. Less than 120 means intensive treatment, less than 140 this is a standard treatment. The primary composite outcome was myocardial infarction, other acute coronary syndrome, stroke, heart failure, and the study was prematurely terminated because of the advantages of intensive treatment. So it opened the horizon for the goal for intensive treatment for hypertension because of the beneficial effects of intensive treatment. And this another study, I'll go just after 2 slides to conclude the sector of intensive blood pressure. This is an elderly person. This is a sector from the SPRINT showing 2,636 older adults above 75 years were randomized into intensive less than 120 systolic blood pressure or standard treatment 140 less than 140 in 1,319 cases. This study shows superiority of intensive blood pressure control. Another aspect is the correlation of intensive blood pressure control with mobility. There is no restriction of mobility in these older adults. However, let me just to conclude the issue of SPRINT trial because it carries a dilemma in medicine. Should blood pressure goal be individualized in hypertensive patient? Yes, should be individualized. And regarding the issue of SPRINT, let me to critically appraise SPRINT according to these points. First, Several practical questions have to be considered. First, using an automated measurement system at an office visit during sprint protocol. This is completely different from real practice we follow. While the patient was seated alone after 5 minutes of quiet rest, may likely have resulted in lower blood pressure values than would normally be obtained with a routine blood pressure measurement. So it seems that 120 millimeter mercury in a sprint trial is like 130 in the real practice, in real world office setting. Secondly, careful and repeated examination of sprint participants may have led to fewer adverse events, more frequent in the intensive treatment group than the expected in the real world setting. The safety profile of this intensive treatment approach should therefore remain a matter of concern in clinical practice, especially in elderly patients and diabetic patients, in patients with established cardiovascular disease. Orthostatic hypotension should alert the clinician to hold up titration. Thirdly, beyond the question of blood pressure goal, choice of antihypertensive medications and effective 24-hour blood pressure control are important to consider in the context of blood pressure lowering strategy. In particular, ambulatory blood pressure measurements and during nighttime should be considered for individualization hypertension care. So again and again and again, I'm stressing upon the first sector of this presentation how to measure and monitor blood pressure by following the advices. And again, according to the Canadian guidelines, clinical indication defining high-risk patients as candidate for intensive hypertension control, they may include clinical or the presence of clinical or subclinical cardiovascular disease or chronic kidney disease, non-diabetic patients, proteinuria less than 1 gram per day, estimated GFR between 20 to 59 milliliter per minute per average adult surface area 1.73, or estimated 10 years global cardiovascular risk exceeding or equals 15%, or age above 75. Patient with one or more clinical indication should consent to intensive management, and for myself, I should monitor this patient carefully. If I cannot monitor this patient carefully, it's better not to adopt the intensive control of hypertension. Limited or no evidence for heart failure with low ejection fraction less than 35%, or recent myocardial infarction within last 3 months. Indications for but not currently receiving a beta blocker. And institutionalized elderly, because I'll mention it in a minute. Inconclusive evidence for diabetic prior stroke with estimated GFR less than 20, contraindicated. This is a very important point to be known. Intensive blood pressure control is contraindicated in patients unwilling or unable to adhere to medical medication. Standing blood pressure systolic less than 110. Inability to measure systolic blood pressure accurately. Non-secondary cause of hypertension. So should search of these points before adopting the policy of intensive blood pressure control. Regarding institutionalized individuals older than 80 who are very fragile, here the reaching systolic blood pressure less than 130 using more than 2 medication. Here this less than 2 medication is excellent, but here survival is drastically reduced if we used more than 3 medication to reach this goal. Again, we should look at the other comorbidities like portion hypertension and others before we advise these points. Again, we should follow the tolerability for antihypertensive medications, because tolerability depends upon many factors like age-related physiological changes, altered in body weight, decline in body water, relative increase in body fat, decline in muscle mass, alteration in gastrointestinal function, alteration in hepatic function, decline in renal function. All this can occur with aging. Pathological situations like gastrointestinal diseases, disorder of body compartment like edema, dehydration, obesity, and wasting, altered hepatic function, liver disease, acute renal failure, heart failure. All this should be put in mind because it manipulates drug tolerability and increase adverse effects. Interaction that influence drug kinetics and dynamics. Here, drug interaction like non-steroidal, blunt the effect of diuretics and ACE inhibitors. Disease interaction ACE inhibitor or ARBs may worsen pre-existing impairment of renal function and hyperkalemia, diet, interaction of salts, polypharmacy. So we should tackle all these before deciding to follow intensive blood pressure control. So reaching the third destination, the nephrology perspective of blood pressure control. Hypertension in chronic kidney disease is relatively common, and we usually are confronted by the hypertension in chronic kidney disease. And in the absence of proteinuria, I think values less than 135/85 has no additional benefits. And with proteinuria, we may reduce this target to 130/80. It may be helpful. In dialysis patient, it's completely different because we don't know exactly the standard, the best blood pressure in systole, because systolic blood pressure between 150 to 160 and diastole 90, it seems that there is no added untoward cardiovascular effects. So to achieve blood pressure target in dialysis patients is another different story, because in this scenario it's better to stress on the blood volume. This is an old slide, but I like it, and I think it seems that it's still working. For chronic kidney disease patients, here I wrote diabetic and non-diabetic, and I think it can be valid for us. Here, blood pressure is above 140/90, and albuminuria is A1, is less than 30 milligram per gram creatinine. The target will be just 140/90 or less, and the agents any antihypertensive, and the grade was 1B. If the albuminuria is exceeding 30 to 300 or above 300, this is the situation to reach 130/80 using ACE or ARBs. And if the proteinuria or albuminuria is high, the evidence for ACE inhibitors or ARBs increases. So this is, I think it's essential. Again, when we use the drugs, we should know what the drugs that we are using. If we selected RAS blockers, RAS blocker may increase acute kidney injury. If we look at these different AC inhibitors, captopril, lisinopril, perindopril, ramipril, can find here the main elimination route is through the kidney. And for these ERPs, cansertan, losartan, or mesartan, tilmesartan, valsartan, the major route of elimination is through hepatic excretion. So it seems that there is differential pharmacokinetics between ACE inhibitor and ERBs. If we look at comparing, this study was conducted on elderly persons. If we look at the difference in the incidence of acute kidney injury, if we use ACE inhibitors or ERBs, the incidence of acute kidney injury is significantly higher than other drugs. If we compare ACE inhibitor versus ARBs, acute kidney injury occurs more common with ACE inhibitor than ARBs. And here, using ACE inhibitors that need dose modifications, so we use them with overdose, acute kidney injury occurs more and more. So the advice is, we shouldn't use ACE inhibitors or ARBs if the patient is dehydrated. It is wise to start either with diuretic until the patient stabilizes, or ACE inhibitor until the patient stabilizes, and then adding the second drug, because starting with ACE inhibitors and diuretics increases this risk. The second point, the drugs that need modification should be modified, and we should avoid overdosing all through. But again, don't forget to not to use these drugs with the presence of dehydration, and you can think of temporary withdrawal in a case of dehydration. Effect of aging. This is the largest series, including 300,000 patients with incident chronic kidney disease, showed the correlation of systolic blood pressure with mortality. If we look at the young age, the correlation between systolic blood pressure and mortality follows U-shaped curve. So lower systolic and high systolic blood pressure have bad side effects and increasing mortality. And this issue was planted in the age of 80 years. Which is more consistent is the correlation of high systolic blood pressure with the incident in end-stage kidney disease all through the different age ranges. Again, intensive blood pressure and chronic kidney disease. A recent trial data suggests intensive blood pressure lowering chronic kidney disease that can reduce cardiovascular morbidity and potentially cause mortality. As I mentioned, we should focus on the proper way of blood pressure recording and to proper monitoring of our patients. Attention should be paid to blood pressure measurement when deciding what threshold target is used for intensive blood pressure lowering in non-diabetic chronic kidney disease. Again, in dialysis, as you see, there is in here the between 140 to even 170, or there is no difference here in the hazard ratio. So again, the standard blood pressure in dialysis is not well known. However, there is an old dogma that pre-dialysis blood pressure should be 140/90 and not to be less than 130/80 at the end of dialysis. Another important point is intradialytic hypertension that may be confronted in more than 10% of dialysis patients, and this slide summarizes by different ways how intradialytic hypertension occur, and the majority are either through preservation of intravascular fluid volume or increased vascular resistance. So we should think of the blood volume to avoid the intradialytic hypertension. Another point is to look at the dialysability of drugs. So even if we use beta blocker, it's better to use carvedilol rather than atenolol. And we know that S inhibitors are dialysable, ARBs are not dialysable, so we may select the best drug that hit the management of these patients. Dialysate sodium reduction remained the only intervention to avoid the increasing the weight gain, increasing the volume. So it is to put in mind recurrent because it was observed in that intradialytic hypertension is ameliorated with using low sodium dialysate in an uncontrolled study. Although the pathophysiology behind intradialytic hypertension is currently clear like this, however, we need further studies to tackle this point. Let us to go to the interesting data about renovascular hypertension. Renovascular hypertension either to be unilateral like this. If it occurs unilateral, in this side you can find increasing renin-angiotensin system. However, the RAS system is suppressed in the contralateral non-stenotic kidney with increasing sodium excretion, so there is no volume. So the unilateral renal artery stenosis is a model of renin-induced hypertension. But if we look at bilateral model or isolated kidney, solitary kidney renal artery stenosis, there is increasing at the end, there is increasing volume expansion, so it is volume dependent hypertension. We may think of renovascular hypertension if we are dealing with early or late onset hypertension below 30 years or above 50 years. Blood pressure is accelerated, acceleration of treated hypertension, deterioration of renal function in treated essential hypertension, acute renal failure during treatment of hypertension, especially with S inhibitors exceeding 30% of the baseline creatinine, flash pulmonary edema, progressive renal failure, acute heart failure. All these parameters are known for renovascular hypertension. And if we want to summarize them, duration less than 1 year, onset over age 50, grade 3 to 4 optic fundi, abdominal berui, and so these are the clinical features favoring renovascular hypertension. Look at syndromes and look at the association. This is an interesting point because here I want to discuss with you how to diagnose renovascular hypertension. This is the CT scan from a 72-year-old woman with a solitary functioning kidney. Duplex ultrasound revealed artery stenosis because the peak systolic velocity is exceeding 5 meters. Reflecting severe degree of vascular occlusion. Although the nephrogram appear well preserved, here you find Tardus Barvas wave suggesting artery stenosis. Here in this case, after using ARBs, the patient suffering from acute renal failure, creatinine reaches 4.5 milligram per deciliter. After a stoppage of ARBs, there was reduction of creatinine, but severe hypertension and episodes of flash pulmonary edema occurred. So renal vascularization for this case was successful with elimination of congestive heart failure, reinstitution of ARBs, and stable kidney function. Here I want to discuss with you what the facilities to be used for diagnosis of renal vascular hypertension. Let us go to some agreement. CT angiography currently over better is better resolution. MRA has advantages of avoid radiation. The main limitation of this imaging is the risk of contrast nephropathy with CTA and the risk of nephrogenic systemic fibrosis with MRA if the patient GFR is less than 15 or 30 ml per minute. Regarding captopril, I don't like it generally for diagnosis of renal vascular hypertension because in the past captopril studies using captopril have been used to evaluate renal vascular disease. However, this test doesn't distinguish reliably unilateral from bilateral renal artery stenosis. Among patients with bilateral disease, asymmetry was identified in the more severely affected kidney, but the presence or absence of stenosis in the contralateral kidney couldn't be assured. Importantly, renogram sensitivity and specificity decrease with decline in renal function, especially for patients who have serum creatinine greater than 2 milligram per deciliter. As a result, elastoprenography is less commonly used in the current era and has value primarily to evaluate the relative function of each kidney before considering therapeutic nephrectomy, and this is our deal. If we have a patient with severe hypertension and the MRA revealed renal vascular hypertension in one kidney, and you will find by renogram that the function of this kidney is very, very low. We are late. So this patient will not get the benefit of revascularization. And if we think of management of hypertension in this setting, we may think of nephrectomy based on renographic assessment of the kidney with stenosis. Let us go to the most important point and that address a question. Is revascularization a solution for renal vascular hypertension? The simple answer is no. Why? Because if you look at STAR, Astral, Coral trials that discuss the issue of revascularization, you can find no difference between revascularization and the proper medical treatment. So the revascularization is left to clinical indication. So appropriate care can be considered by using revascularization in a significant renal artery stenosis that is associated with cardiac disturbance syndrome, flash pulmonary edema, or acute pulmonary syndromes or severe hypertension, resistant hypertension uncontrolled with failure of maximally tolerated doses, at least 3 hypertensive agents. One of them is diuretic, intolerant medication, ischemic nephropathy with chronic kidney disease, with estimated GFR less than 45 ml per minute, and global renal ischemia, unilateral significant renal artery stenosis with isolatory kidney or bilateral significant renal artery stenosis without other explanation. Maybe appropriate care in unilateral renal artery stenosis with CKD, GFR less than 45, unilateral renal artery stenosis with prior episodes of congestive heart failure, anatomically challenging or high-risk lesions, rarely appropriate care. So it is rarely to be followed in lateral solitary or bilateral artery stenosis with controlled blood pressure and normal renal function, unilateral solitary or bilateral artery stenosis with kidney size less than 7 centimeters in bone-to-bone length, unilateral solitary or bilateral renal artery stenosis with chronic end-stage renal disease on hemodialysis for more than 3 months, unilateral solitary or bilateral renal artery chronic total occlusion. So we should think of all these. The renovascular intervention is essential when is clinically indicated. But to put as a choice from the beginning, it is not a standard of care. According to the Canadian guidelines, patient presenting with 2 or more of the following clinical clues listed below suggesting neurovascular hypertension: sudden onset of worsening hypertension in age above 55 or less than 30 years, presence of abdominal puree, hypertension resistant to 3 drugs or more, increase in serum creatinine by more than 30%, associated with the use of angiotensin converting enzyme inhibitors or ARBs, other atherosclerotic renal vascular disorders, particularly in patients who with a stroke or have dyslipidemia, recurrent pulmonary edema with hypertensive changes. Fibromuscular dysplasia is considered with at least one of the following clinical clues: age less than 30, especially in non-obese women, hypertensive, state resistant to more or 3 drugs, significant more than 1.5 centimeter unexplained asymmetry in kidney size, abdominal puree without apparent atherosclerosis, fibromuscular dysplasia in another vascular territory, positive family history of fibromuscular dysplasia. Fibromuscular dysplasia appears within the CT or in angiography as beaded string in the vessels. Regarding the management of the guidelines for non-diabetic coronary kidney disease, ACE inhibitor with proteinuria, ACE inhibitor or ARBs. If there is proteinuria, diuretics as additive, combination of additional agents, careful monitor of renal function when using RAS blockade. Renovascular disease don't affect initial treatment recommendation. Atherosclerotic renal artery stenosis should be primarily managed medically, while revascularization should be considered for renal fibromuscular dysplasia. Combinations, caution with ACE inhibitors or ARBs, bilateral renal artery stenosis, or lateral disease with solitary kidney renal artery angiography and stenting could be considered for patients with renal artery stenosis and complicated uncontrolled hypertension. Let us go to another sector in the nephrology domain of hypertension, which is post-transplant hypertension, and I want to stress on calcineurin inhibitors like cyclosporin or tacrolimus. So in this cartoon, tacrolimus induces hypertension and hyperkalemia through tacrolimus acts on sodium chloride co-transporter in the distal convoluted tubule. It stimulates this co-transportation, so it leads to salt-sensitive hypertension due to increase of sodium reabsorption. If sodium reabsorption increases within the distal convoluted tubule, sodium-rich collecting ducts is reduced. The sodium-rich collecting duct is the main stimulus for potassium secretion. So reduction of sodium reaching the collecting ducts will inhibit potassium secretion. So the end is tacrolimus will lead to hypertension and hyperkalemia. If you want to give diuretics for this, the best treatment will be the drug that will hit the pathophysiology. So drug that inhibit the site of action of tacrolimus on the distal convoluted tubule, that inhibits sodium chloride co-transporter within the distal convoluted tubule, will be the best treatment. So thiazides is the best drug to be used in this scenario. So long as we're speaking about transplantation, there is a correlation between inflammation, immunity, and hypertension. And if you look at this slide and this figure, you can see different sites. Here, inflammatory cytokines promote vascular fibrosis and retraction. Inflammatory cytokines augment angiotensinogen production by proximal tubular cells. Interleukin 17 sustain proximal sodium hydrogen expression, reducing pressure natriuresis. Here in the sick ascending limb of Henle, interferon gamma increases sodium potassium chloride activation. Here the interferon increases expression, interferon gamma, and interleukin 17 contribute to sodium chloride activation. So again, there is a correlation between immunity and hypertension. Regarding the other kidney problems like stones, antihypertensive medication, the risk of kidney stone in older adults, in conclusion of this article, in relation to beta blockers, thiazide diuretics were associated with decreased risk of kidney stone formation, because all of us know that thiazide diuretics have hypocalciuric effect. So it decreases calcium through the urinary tract. So this is why thiazide is associated with low risk of stone for these patients aged above 65 years. Whereas ACE inhibitor, ARB, and the calcium channel blockers have a comparable risk of presenting with the kidney stones. So the only drug with drastic reduction of stones is thiazide. If we have a patient who is treated by shockwave lithotripsy, we should monitor this patient because stone may be complicated by medical disease, and one of these medical diseases is hypertension according to this study. So after shockwave lithotripsy, it's better to monitor blood pressure. Regarding Systolic Hypertensive Therapy, alpha blockers may help in management of urethral stones, so it may be an advantage of using alpha blockers to help in stone expulsion. Is there a relationship between the use of antihypertensive drugs and renal cell carcinoma? It is very debated. However, this is just giving a data showing that the history of hypertension, papillary renal cell carcinoma, was associated with long-term use of diuretics and the calcium channel blockers. Again, this is a debated issue, but to be put in mind in further studies. The fourth gate is diabetes and hypertension. This is one of interesting reviews showing that if we treat systolic blood pressure which is above 150 by antihypertensive treatment in a diabetic patient, this will be associated with reduction of all-cause mortality, reduction in cardiovascular mortality, reduction in myocardial infarction and interstitial disease. If the systolic blood pressure between 140 to 150, and we give blood pressure lowering therapies, this will be associated with beneficial effect on the all-cause mortality, myocardial infarction, and heart failure. But if we start antihypertensive treatment while blood pressure is still normal, less than 140, this will increase the harm, increasing cardiovascular mortality, and maybe increasing all-cause mortality. Another interesting point is just to there is a correlation between certain drug and diabetes up to this moment, and according to this review, there is no convincing evidence to support using any antihypertensive agent above the other to prevent death, cardiovascular disease, or interstitial disease in diabetic. Therefore, choice of agent should not differ in people with diabetes compared with general population. Future research should focus on patients with type 1 diabetes and very elderly patients with type 2 diabetes. So the available evidence support treatment in people with type 2 diabetes and systolic blood pressure more than 140 using any of the major antihypertensive drug classes based on this review. This was the guidelines from Canada last year. So systolic blood pressure equal or exceed 140, start antihypertensive treatment. And patient with diabetes and hypertension, use of any first line antihypertensive drug as I mentioned. And patient with proteinuria, it is better to use ACE inhibitors. The blood pressure should be treated to the lower than 140 over 90. We don't like systolic blood pressure to be less than 120 in diabetic patient, except in the families with stroke. And if we allow for intensive blood pressure control, we should have the facilities for proper monitoring side effects and the patient outcome in these patients. There are new this year's. This is the new guidelines from Canada. Persons with diabetes mellitus should be treated to attain systolic blood pressure less than 130. So this is new. And diastole less than 80. So 130, 80. This is a grade A. These target blood pressure levels are the same as blood pressure treatment threshold. Combination therapy using two first-line agents may also be considered as initial treatment for hypertension, grade B. If systolic blood pressure is 20 mm mercury greater than target, or diastolic is greater than 10 mm mercury than target. However, caution should be exercised in patients in whom sustained decrease in blood pressure is more likely or poorly tolerated, elderly, and patients with autonomic neuropathy. For persons with cardiovascular or kidney disease, including microalbuminuria or with cardiovascular risk factors, we don't like microalbuminuria, but it is A2 or A3. Microalbuminuria is considered now A2, means 30 to 300 milligram albumin per gram creatinine, or 3 to 30 milligram per millimole creatinine. With cardiovascular risk factors, in addition to diabetes and hypertension, if there is albuminuria, A2 or A3, plus other cardiovascular factors and diabetic, ACE inhibitors or ARBs or angiotensin blockers is recommended as initial treatment grade A evidence. For patients with diabetes and hypertension not included in other guidelines in this section, appropriate choice include in alphabetical order ACE inhibitor A, ARBs or ARBs B, dihydropyridine, calcium channel blocker A, thiazide, diuretic grade A. There is a special issue if we are dealing with diabetic nephropathy with nephrotic range proteinuria and there is refractory hypertension. Is there a rule for selective drug? Yes. According to the weak evidence, we may use amiloride. Why? Because there is a problem with nephropathy with proteinuria. There is a leak of plasmin system that will lead to proteolysis activation of sodium channels in the distal nephron. Activation of sodium channel allows in current of sodium. So blocking the sodium channel by using amiloride will help in management of proteinuria-induced hypertension in these patients. Another advancement in diabetic kidney disease and diabetic nephropathy is to use non-traditional, newly introduced mineralocorticoid receptor antagonist like phenyrenone, which is non-steroidal mineralocorticoid receptor blockers with low risk of hyperkalemia. The fifth stop here will be pregnancy and hypertension. The hypertension disorder of pregnancy are classified into preeclampsia, chronic hypertension with superimposed preeclampsia, gestational hypertension. What the difference? Criteria for preeclampsia are: preeclampsia is diagnosed in the setting of hypertension in association with thrombocytopenia, impaired liver function, the new development of renal insufficiency, pulmonary edema, or new onset cerebral or visual disturbance. In practical manner, the presence of hypertension beyond the 20 weeks of gestation, the second half of pregnancy, plus proteinuria is enough for clinical diagnosis. Chronic hypertension and hypertensive requirement before pregnancy, or hypertension starts before the 20 week of pregnancy, or hypertension continuing for more than 12 weeks after delivery is considered as a case of chronic hypertension. Chronic hypertension with superimposed preeclampsia is a combination of the preeclampsia and chronic hypertension. Gestational hypertension is the blood pressure elevation after 20 weeks of gestation in the absence of proteinuria, thrombocytopenia, impaired liver function, absence of new onset of kidney dysfunction, pulmonary edema, or new cerebral or visual disturbance. So it is just blood pressure component of preeclampsia. So gestational hypertension is just increasing blood pressure beyond after the 20 weeks of gestation. Sometimes we need to differentiate preeclampsia from other syndromes. So this slide shows the difference between preeclampsia and pheochromocytoma. You can look at difference here. The pheochromocytoma occur at any time during pregnancy. Paroxysmal or cystic hypotension is there. Pedal edema is absent. Headache present. Autonomic dysfunction is there. Weight gain is absent. Abdominal pain absent. Proteinuria absent. Maybe elevated glucosuria. Normal liver transaminases. Elevated catecholamines and normal platelet. So these discriminate pheochromocytoma from preeclampsia. Regarding the use of antihypertensive treatment, we have first-line drugs, alpha-methyl dopa, nifedipine, and labetalol. Alpha-methyl dopa may not be able to correct severe hypertension if we are dealing with pregnancy and chronic kidney disease. Is associated with autoimmune manifestation. Side effects of peripheral edema may be more relevant in CKD patients if we use nifedipine, and there is a careful use of nifedipine if the patient is treated with magnesium for treating severe preeclampsia or eclampsia. Labetalol side effects of dizziness and or cystatic hypotension may be particularly relevant in some CKD patients. Second line choice include beta blockers. Depression and fatigue may be particularly relevant in CKD patients. So atenolol is D, FDA label D, bendolol B, metoprolol C, clonidine alpha blockers or systolic hypertension may be important, in particular in patients with baseline neurological impairments, including diabetic nephropathy. Diuretic is B. The old dogma is to stop diuretics is not valid so long as the patient is edematous, but careful starting diuretics should be adopted. Careful approach should be adopted to avoid any side effect of the use of diuretic. But if the patient is adjusted and treated already with diuretics and no signs of dehydration, it's better to keep diuretics in case of pregnancy. Regarding the use of ACE inhibitor and ARBs, generally speaking, we shouldn't start them with pregnancy. They are absolutely contraindicated within the pregnancy. And if we are dealing with hypertensive in a chronic kidney disease patient, and the patient has pregnancy, the attitude toward the ACE inhibitor is different from a school to another. So we have two schools. The first one is focused on risk of child and suggests that ACE inhibitor and ARB shouldn't be used in women who wish to start pregnancy to avoid either all-time exposure or inadvertent exposure during the first 10 weeks, because the using of ACE inhibitors and ARB may lead to renal failure and lung hypoplasia, and even neonatal death and intrauterine fetal death. A second approach underlying the advantages of kidney protection in the presence of proteinuria and suggests to limited risk in early pregnancy to discontinue the drug. So just to elaborate this, we can use ACE inhibitor and ARB in the first trimester, but beyond the first trimester, it's completely contraindicated. If we don't have good monitoring, it is better to avoid ACE inhibitor and ARBs if we think of pregnancy. Before giving ACE inhibitors and the ARBs in childbearing period, we should ask about the pregnancy test results, because this is very crucial. So again and again, ACE inhibitor and ARB should be contraindicated beyond the first trimester, cautiously before this, and they who will decide it is the presence of the best care and the best attendance. And another important point, antihypertensive therapy in lactation. In general, drugs that are bound to plasma proteins are not transferred to breast milk. So lipid-soluble drugs may achieve higher concentration than water-soluble drugs. Neonatal exposure to methyl-dopa, diltiazem, propranolol, enalapril, captopril, and nifedipine via nursing are low. And these medications are considered safe during breastfeeding. Atenolol and metoprolol are concentrated in breast milk and should be avoided, so they are not recommended. Labetalol can be detected in breast milk but has not been associated with adverse events in the infant. Finally, although the concentration of diuretics in breast milk is low, these agents, what's your opinion, to be used or not? These agents may reduce milk production as a result of mild volume contraction and may interfere with the ability to successful breastfeeding, to be avoided with pregnancy. Regarding diuretic and beta blocker, very fast. These are the different diuretics that we have. And here, if you look at chlorothalidone, have a long half-life, so it's better to start with chlorothalidone. And the alternative is indapamide. If the patient has manifest volume overload and especially with chronic kidney disease, loop diuretics is superior than thiazide in these scenarios. Torsemide may have some mineralocorticoid effect. So this should be put in mind. The aldosterone reducing effect of torsemide, which causes less kaliuresis than other diuretics, and it may be beneficial in heart failure, but there are no randomized trials to confirm the potential in human. So please look at the table the onset, peak, half-life, duration. Again, thiazide is the best to be used in uncomplicated hypertension. Long-term thiazide like chlorosylidone or hydrochlorothiazide may be used. Indolamide is a good alternative. If we think of loop diuretics, the best will be, we should know if it is short-lived, we use it twice per day. If it is long-lived, we use once per day. Torsemide have some aldosterone reducing effect, so cause this caliuresis. So to put in mind when we select loop diuretics, it's very important because diuretic is an important stop in management of hypertension. Regarding beta blocker, this is the Cochrane Reverb groups. They addressed this issue in systematic review. Atenolol was the beta blocker that's mostly used in the many studies. Current evidence suggests that initiating treatment of hypertension with beta blocker leads to modest cardiovascular disease reduction and little or no effects on mortality. These beta blocker effects are inferior to other drugs of antihypertensive. Further research should be of high quality and should explore whether there is difference or not. Again, I don't like beta blockers in management of hypertension except if there is compelling indication like heart failure, like atrial fibrillation, etc. So in this this is the table that shows the different beta blockers, daily dose, half-life, route of excretion, selectivity, intrinsic sympathetic activity, alpha-1 antagonistic activity, membrane stabilizing effect, and vasodilator function. Here nebivolol have vasodilator properties that I'll address later. So beta blocker are recommended for first-line treatment of heart failure, coronary artery disease, and atrial fibrillation, as well as of hypertension complicated with heart failure, angina pectoris, or prior myocardial infarction. Beta blocker shouldn't be withheld from patients with diabetes mellitus or chronic obstructive pulmonary disease, although cardioselective agents are preferable. This is the updated systematic review regarding nebivolol, showing that the side effect of controlled blood pressure in patients with hypertension, this third generation beta blocker offer additional benefits for central hemodynamics and neutral or beneficial metabolism. Nebivolol exert neutral or beneficial effect on insulin sensitivity and lipid metabolism in hypertensive patients, owing to its nitric oxide mediated vasodilator property and antioxidant properties. Thus, nebivolol could be a favorable therapeutic option for treatment of hypertension in patients with impaired glucose and lipid metabolism. So this is another addition. For patients with erectile dysfunction, we know that erectile dysfunction is the most common symptom in men. Nebivolol, because it preserves nitric oxide, has vasodilator, so it may be advantageous to be used. It's facilitate benign erection. So when we think of beta blocker in patients with erectile dysfunction, it's better to select nebivolol. Again, from the up-to-date, you can find the drug interaction with beta blockers. So here, aluminum hydroxide gel, avoid beta blocker aluminum hydroxide gel combination. Aminophylline mutual inhibition, so they inhibit each other. So you can look at every drug and its possible effects with beta blockers and the precautions. This is the very exhaustive list to be put in mind when we think of beta blockers and drug interactions. Regarding drug interactions, calcium channel blocker and antibiotic interaction, calcium channel blocker metabolism is inhibited by clarithromycins. So it's better to avoid clarithromycin for patients who are already on calcium channel blockers, especially dihydropyridine calcium channel blockers, because of the risk of acute kidney injury and hypertension in this scenario, because clarithromycin increases the different calcium channel blockers blood levels. Again, if the patient is treated because of latent TB or even active TB and he is hypertensive, respect to monitor blood pressure if the patient is treated with rifampicin, because rifampicin can accelerate the metabolism of beta alpha blockers, calcium channel blockers, and angiotensin receptor blockers. All these to be put in mind for monitoring of blood pressure and adjusting the dose. Other issues regarding the relatively new class of treatment, which is beta angiotensin receptor blocker, sacubitril, valsartan, which is ARBs, with sacubitril, which is neprilysin inhibitor. Here, valsartan is known as ARB molecule. Sacubitril inhibit neprilysin. Where is neprilysin? Neprilysin is here, leads to catabolism of natriuretic peptides. So if you block the metabolism by neprilysin inhibitors, which is sacubitril, in this combination, this will lead to vasodilatation, decreasing blood pressure, decreasing sympathetic tone, decreased aldosterone level, decreased fibrosis and hypertrophy. So all these are advantages beside the use of classical angiotensin receptor blockers. I attended this presentation of Professor Magdi Abdel Hamid during the 18th Dumyat conference this month, when he discussed the recent management of heart failure, and this is one from his slides reflecting the guidelines of treatment of heart failure. Heart failure ACE inhibitor is recommended in addition to beta blocker for symptomatic patient with reduced ejection fraction. A beta blocker is recommended in addition to ACE inhibitor for patient with stable symptomatic heart failure with reduced ejection fraction. Mineralocorticoid receptor antagonist is recommended as added on treatment because it helps a lot and the level of evidence is A. Again, ACE inhibitor, beta blockers, and mineralocorticoid receptor antagonists. And the new class which I am discussing, which is the valsartan, sacubitril, neprilysin inhibitor plus ARBs, here recommended and level B. And here it is better to, if the patient is already maintained on ARBs, we can stop ARBs and give him this combination. Or if the patient is treated with inhibitors, we can stop for a day or 36 hours and starting the sacubitril valsartan combination. So this is an advances in heart failure. In atrial fibrillation, this is a very nice presentation. Atrial fibrillation, hypertension, facing killer union. So atrial fibrillation and heart and hypertension are bad for the patient situation. This is a very nice article discussed the issue of blood pressure in patient with atrial fibrillation. So to protect against development of atrial fibrillation, it's better to use RAS blockers, because RAS blocker leads to improvement of remodeling of atrium and ventricular muscles. So it protects against development of atrial fibrillation. And using them, they may also protect against the recurrence of atrial fibrillation after management of atrial fibrillation. Using beta blocker is important, or non-dihydropyridine calcium channel to control heart rate is essential in these scenarios. Regarding hypertension in surgery, it's a very critical situation. If you have hypertension peri-operative, how to deal with the antihypertensive medication. And this, if you read this chapter of this book, you will reach the summary. Relative few published studies have evaluated the management of hypertension during peri-operative period. The evidence supports that most stable patients, regardless of their surgical risk, who have only mild to moderate hypertension, don't require further risk assessment or blood pressure lowering intervention before surgery. Individuals at elevated cardiovascular risk who also have blood pressure of 180/110 or higher may be at excessive risk of peri-operative complication. Based upon precautionary principles, we suggest that these patients should have their severe hypertension addressed by individualized treatment approach before proceeding with surgery. Additional clinical trials are needed to provide stronger evidence-based management in patients with hypertension during the peri-operative periods. Antihypertensive medication throughout the peri-operative periods, including on the morning of surgery, the dosage of medication may be adjusted or even held like ACE inhibitor or ARBs as clinically indicated, because we are afraid of the hypotension during the surgery and ischemia of the organs. So we can stop if the blood pressure is accepted and to be monitored well. But regarding the drugs with rebound hypertension, it is obsolete to be discontinued. So it is critical to emphasize that patient should not stop or withhold agents preoperatively that commonly provoke rebound tachycardia and or hypertension, principally beta blocker. So it's better to know the blood pressure values, antihypertensive medication, stress management, and then to decide. So you can go through this algorithm, looking at the cardiovascular risk factors, looking at the values of systolic blood pressure and the diastolic blood pressure, and the choice of medications. Again and again, we can sometimes hold S inhibitor or ARBs if the blood pressure is adequately managed perioperatively to be monitored well, but to avoid altogether stopping the drugs like beta blocker because of we are afraid of rebound hypertension and arrhythmia. Regarding secondary hypertension, this table summarizes the suggestive clause: severe resistant hypertension, an acute rise in blood pressure over previously stable values, proven age of onset before puberty, age less than 30 years, with family history of hypertension and no obesity, and for renal disease I discussed it, primary renal disease, serum creatinine, use of different drugs, and other situations like primary aldosteronism. So the presence of hypokalemia is important. Cushing syndrome, Cushing fissures. So we should think of secondary etiology when we deal with severe hypertension or resistant hypertension. So consider testing for primary aldosteronism if the patient is suffering from hypertension and hypokalemia, resistant hypertension using 3 drugs and poor blood pressure control, adrenal incidentuloma and hypertension, onset of hypertension at younger age, severe hypertension above 160 systole and 100 diastole, whenever consisting secondary hypertension. Case detection testing, monitoring blood sample in seated ambulant patients, plasma aldosterone. This is the plasma aldosterone concentration and plasma renin activity, and if plasma renin activity is suppressed, this is the plasma aldosterone concentration is high. This is the CLO, and the confirmatory test is 24-hour urinary aldosterone on a high sodium diet. In obesity and hypertension, in obese there is a problem in salt. So normally blood pressure increases, natriuresis occur, but this curve of pressure natriuresis is planted in obese patients. Visceral obesity even may release aldosterone releasing factors that stimulate aldosterone, so stimulating sympathetic nervous system activity, renin-angiotensin system. All these can at the end lead to hypertension because of obesity. If we treat obesity hypertension patient, the using diuretics is essential as combined with ACE inhibitor rather than calcium channel blockers, because volume is important in obese induced hypertension. Obesity induced hypertension may be a repercussion and translation of obstructive sleep apnea, so we should think of obstructive sleep apnea whenever we have obese with hypertension, and because obstructive sleep apnea lead to a reduction in parasympathetic nervous activity, decreasing oxygenation, increasing PCO2, decreasing intrathoracic pressure. At the end of the day, you can find the hypertension and increasing cardiovascular risk factors. So we should think of that. We should monitor. In these scenarios, we may add aldosterone receptor blockers, or thinking of oral appliances for management of or CPAP for management of obstructive sleep apnea. Whenever we have resistant hypertension, search for the contribution of added drugs. So these are the prescription drugs that are associated with hypertension or increasing the level of blood pressure beyond the control: anabolic steroid and depressants, norepinephrine, calcineurin inhibitor, cyclosporin, tacrolimus, and discuss it in the scenario of sodium chloride transporter, stimulation of this convertible glucocorticoid, erythropoietin, contraception. So we can consider contraception is the major cause in the childbearing period in females. Non-steroidal anti-inflammatory drugs, sympathomimetics, VEGF inhibitors, tyrosine kinase inhibitors, amphetamine. So the list of drugs is exhaustive, showing that drugs may worsen the control blood pressure. Even non-prescription drugs like anabolic steroid, caffeine, cocaine, ethanol, NSAID, alpha adrenergic herbal supplements, all this may lead to uncontrolled hypertension. Again, spironolactone given in small or moderate dose from 25 to 50 milligram may help a lot in management of resistant hypertension, so can be added as a fourth drug for management of hypertension. So as you see, adding spironolactone in small dose reduces systolic and diastolic blood pressure, but be careful because it may increase the risk of hyperkalemia or withdrawal because of side effects. So it is a good additive. Apparent mineralocorticoid excess, another points to be known in this syndrome. This is a genetic disorder causing severe hypertension, hypokalemia, and hyporenemic hypoaldosteronism. Hypoaldosteronism with hypokalemia and hypertension, this is to say apparent. It's not mineralocorticoid excess, it's apparent. And the main defect is deficiency of 11 beta hydroxysteroid dehydrogenase enzyme type 2. And this enzyme is responsible about the transfer of cortisol into cortisone, so it protects aldosterone receptor. If the enzyme is inhibited by the syndrome of genetic related hypertension, cortisol will act on aldosterone, leading to hypertension. The best treatment is to block the aldosterone receptor by using the mineralocorticoid receptor blockers. The correlation of hyperuricemia with hypertension is shown from this study that hyperuricemia, especially in women, if serum uric acid exceeds 6.8, is correlated with severe hypertension, and this is the beyond the theoretical backgrounds. The elderly hypertension patients will lead to chronic kidney disease, increasing uric acid. Increasing uric acid, this is our topic. It associated with increasing arterial stiffness, vascular remodeling, resistant hypertension. So how to treat resistant hypertension? It's better to know some words about renal denervation. The issue of renal denervation as shown in this slide, and this is a very nice review regarding renal denervation: kidney injury, ischemia, inflammation, or pelvic pressure activates afferent renal sympathetic signals and stimulates the central nervous system. So afferent stimulates central nervous system with efferent signals. So central sympathetic outflow, which in turn raises blood pressure by increasing cardiac contractility, vasoconstriction, renal angiotensin aldosterone system, salt retention. Renal denervation interrupts all these, interrupts both afferent and efferent renal sympathetic signals. And if you read all through this review, the conclusion is the landscape for renal denervation evolves, continued innovations in the denervation technology, development of tools to better assessment the real time success of denervation, the refinement in the ability to identify individuals who are most likely to benefit from denervation will ultimately inform whether renal denervation represents a viable method of managing and controlling hypertension in the future. Because up to this up to date information, the role of renal denervation is debatable in management of resistant hypertension, and this is the, I think, the same conclusion from this Cochrane review group. Current evidence is inconclusive to support the use of renal denervation to improve cardiovascular and renal risk and blood pressure control in patients with resistant hypertension. Further studies are needed with refinement of the technique. And if we think of interventional management for resistant hypertension, we have renal denervation and we have the carotid bodies and renal nerves as therapeutic targets for hypertension. Regarding these two articles are published within the issue of May 2017 and giving us a very nice review about this intervention that they still need further refinement. So the recommendation for management of resistant hypertension confirm treatment resistance. Office blood pressure above 140/90 or 130/80 with diabetes, chronic kidney disease, or coronary artery disease, and the patient prescribed 3 or more, possible with diuretics, or office blood pressure a goal, but patient require 4 or more antihypertensive medication. Exclude pseudo-resistant. Is patient adherent or not? Obtain home, work, or ambulatory blood pressure reading to exclude white coat effect. Identify and reverse comorbid lifestyle, obesity, physical inactivity, excessive salt, low fibers, and then discontinue or minimize interfering substances like non-steroidal, thimbasune, or mimetics, like diet pills, decongestants, stimulants, oral contraception, licorice. All these should be stopped first. Screen for secondary cause of hypertension, obstructive sleep apnea, snoring, witnessed apnea, excessive daytime sleepiness, primary aldosteronism, elevated aldosterone-renin ratio, chronic kidney disease, creatinine, and creatinine clearance less than 30 ml/min, renal artery stenosis, young female, non-atherosclerotic disease, worsening renal function, pheochromocytoma, episodic hypertension, diaphoresis, palpitation, headache, Cushing syndrome, moon phase, etc., aortic coarctation. So I'm stressing on the clinical stigmata of secondary hypertension because of the secondary etiology. We should treat the etiological cause. Pharmacological treatment: maximize diuretic therapy, including possible addition of mineralocorticoid receptor antagonist, combine agents with the different mechanism of action, use loop diuretics in patients with chronic kidney disease, in patient receiving potent vasodilator like minoxidil, refer to specialist, refer to appropriate specialist for known or suspected secondary cause of hypertension, refer to hypertension specialist if blood pressure remains uncontrolled after 6 months of treatment. To conclude the presentation, we should know how to manage hypertension. So goal-oriented management of patients with hypertension can be provided by physicians, pharmacists, nurse, and perhaps other professionals. Coordinated and collaborative models that include interdisciplinary and multidisciplinary care of management have been superior to care provided by individuals. To optimally provide chronic care for patients with hypertension, the entire delivery system needs to be structured to focus on chronic care model. So we need a refinement of healthcare system. We need to know the obstacles and the barriers for the better management of hypertension. If you look at this slide, you'll find multiple barriers. If we are smart enough, we should do our best to know the barriers and know how to overcome the barriers. So tailor the intervention addressing the unique barrier of young adults are needed to improve population hypertension control, augmentation, traditional clinic structure to support the healthy identity of young adults, and self-management skills are promising next step to improve hypertension healthcare delivery. Besides all these efforts, we should do our best to improve drug adherence. This is one of the important points that if we finish the presentation without stressing on drug adherence and the patient education and the tools to monitor drug adherence, this is very interesting and very important to be sure that the patient received all what what is recommended. So again, look at the clinical blood pressure and the barrier for the diagnosis, lifestyle modification barrier to be overcome. So again and again, it is multidisciplinary, and we should look at the patient as a whole. Everything should end. Although it is impossible to cover all the aspects of hypertension in adults in one session, but today I discussed with you different sectors that I like to convey. So, and I want to end with Mahatma Gandhi quotation: live as if you were to die tomorrow, learn as if you were to live forever. So always we are keeping eye on reading, on experience, to know what's new for the management of our patients. Thank you for attention, and I'll be happy to receive your questions through my email. Thank you very much and goodbye. Alhamdulillah.